Hello everyone, and welcome to today's webinar by the Global Antibiotic Research and Development Partnership, GARDP. My name is Shirin Derachani, and I will be hosting today's session on clinical trial platforms for new and neglected antimicrobials. REVIVE is GARDP's education and outreach program. It aims to connect and support the antimicrobial research and development community by facilitating learning, sharing knowledge, and connecting people. These webinars are part of our educational activities. All webinars are recorded and are freely available to view after the live broadcast on our website that you can see here. As well as webinar recordings, you can also read our series of articles known as Antimicrobial Viewpoints, where experts discuss various topics within the field. We also have a resources section that includes the Antimicrobial Encyclopedia. This has definitions on various important terms, and some of these include new videos where experts give a further explanation on the terms. As always, today's presentation will be followed by a question and answer session. You can submit your questions at any time during the webinar via the questions window in your webinar control panel as shown on this slide. We will address the question after the presentations and do our best to respond to as many questions as possible. Today's webinar is done in collaboration with ECRAID, the European Clinical Research Alliance on Infectious Diseases. I am pleased to present to you our speakers for today, Jesús Rodríguez-Baño and Bielicki. Our moderator for today is Marc Bonten. Marc is a professor of molecular epidemiology of infectious diseases and leading the research group of infectious disease epidemiology of the Julius Center of Health Sciences and Primary Care at the University Medical Centre Utrecht. Marc serves on various scientific advisory boards, winner of several awards, and since January 2022, he is the CEO of ECRAID. He has co-authored over 700 scientific publications that has been cited over 40,000 times. Welcome, Marc. I now hand over to you to introduce our first speaker.
Thank you, Shirin. It's my pleasure to moderate this webinar with two good friends and esteemed scientists as speakers. And the first speaker of today is Jesús Rodríguez-Baño from Seville. He's a specialist in internal medicine and an expert in epidemiology and clinical research. He's also past president of the European Society of Clinical Microbiology and Infectious Diseases and was editor of Clinical Microbiology and Infection. He heads the infectious disease division at the hospital Universitario, Virgen Macarena, not sure if I pronounced that correctly, and he's a full professor of medicine at the University of Seville in Spain. Jesús has authored more than 400 peer-reviewed articles and has been a leader or partner in multiple research projects funded by the European Union. He was a member of the scientific advisory board of the GPI-AMR, also of the European Union. His areas of interest include antimicrobial resistance from a clinical epidemiological and a control and treatment perspective, antibiotic use, bloodstream infections, UTI and healthcare associated infections. And I'm now happy to give the floor to him and anxious to see what he will present.
Thank you very much, Marc and Shirin, for the kind introduction. And thank you, GARDP and ECRAID, for inviting me to participate in this very interesting symposium. So I have no conflict of interest for this talk. I receive funding from European Union and from IMI calls. And well, if you think of what are the areas of interest for performing randomized trials in complicated UTI, I would say that there is interest in diagnostic aspect, mostly having rapid identification of etiological pathogens or having rapid susceptibility testing. Also biomarkers for diagnosing clinically the UTI. For treatments, of course, new drugs, but also neglected drugs are very important in research recently. And other management aspects are related to the management of the infection, like, source control and other aspects. But also very important are stewardship considerations, like related to duration of treatment or treatment for oral treatment for some of this infection, and finally, of course, prevention. You know that it's quite frequent that we can read in the literature a pivotal trial performed with intention of marketing one of the new drugs in complicated UTI. This is because this is a, let's say, easy indication for antigram-negative drugs, because UTI are typically considered, let's say, low-risk source of infection in some circumstances, and there's a high probability of success, particularly for beta-lactam or quinolones, aminoglycosides. Typically, the studies include two arms, the new one versus the standard, and there are non-inferiority studies. And there are a number of regulations for the regulatory agencies about the methods. And just summarizing this from the EMA or FDA, you can see, for example, that the criteria for complicated UTI includes retention or obstruction or use of a catheter, FDA functional or anatomical problems. Its studies can include a number of pyelonephritis from 30 to 70%, but typically some important infections are excluded from these studies, like prostatitis or infections associated with ileal loops or reflux, etc., or sometimes organ transplantation. And also typically, as an endpoint, macrobiological response is included. And this is very controversial, whether really macrobiological response should be tested. This is not something that is recommended in clinical practice, but is used as an endpoint typically for these studies. So there are some issues with this recommendation. First is that it includes very different type of infections. Second is that important type of pathogens are excluded. There is typically an underrepresentation of the most difficult bacteria to treat, and the protocols of the trials are not very similar to what we do in clinical practice. So if you see a recent review about this, you can see that even if the regulatory guidelines are strictly followed, there are variable populations, and this can explain the fact that there are different results in different trials, even though they follow all the same regulations. So if we consider as medical doctor, what are the medical needs? When one of the medical needs in complicated cases is the treatment of difficult to treat pathogens, that's clearly an issue, and particularly when we can try to use oral drugs, but the isolates are resistant to oral drugs. Also, complex infection and specific population, as we have discussed, like transplant patients or prostatitis or patients with chronic tract obstruction, etc. And finally, some issues with antibiotic stewardship, like what are the best strategy for empirical treatment in different epidemiological situations? How far can we go for our oral step down and treatment duration? What about neglected drug, and what are the impacts in ecological terms of the different drugs that we use? If you look at the randomized trials that have been published with new drugs that are active against the most resistant bacteria, which are the carbapenem-resistant gram-negative bacteria, and reviewing the trials that are performed specifically for this type of bacteria, you can see that there are a number of trials that have been done. But look at the number of patients that have been recruited, very, very low numbers. Typically, these trials not only include complicated UTI, but include other types of infections, or the UTI typically is the most frequent one. But you can see that we have a problem to do trials, even when they are sponsored by pharmaceutical companies, to recruit patients. So here is something that we need to do better. We have to think of some antibiotics that can be active in vitro against some of the resistant bacteria, but the information available about how to use them, in which situation we can use them, is very limited. And of course, this is an area of huge interest. So what to improve here? So we have to select the patients in a more efficient way. We have to detect them, we have to be able to include them in trials. For that, of course, we need pragmatic protocols that are really adapted to what we do in clinical practice, and that provides information that when transferred to clinical practice really makes sense. We have to use efficient designs to facilitate recruitment. We need to include relevant research questions, as we discussed before. In some terms, we need to discuss about individualized therapy in circumstances where the options are very limited. And of course, we should consider patients' preferences as outcomes, and of course, the ecological impact of the different drugs. So if you look at what is the procedure or how we treat a patient, we start with an initial workout. We decide about empirical treatment, can be oral or intravenous, one drug or the other. Then we start to assess early response. We have the macrobiological results, and we can go for a targeted therapy. We can consider oral switch during the course. We can consider discharging the patient early, and then do any follow-up and assess for recurrent reinfection. So it's the complete way that the patient goes through that we would like to examine and have information from a clinical trial, and not just for one of these specific points. So we need to think how to implement that in our trials. So just an example of for one side the difficulties, and from the other side some recent results. This is a trial that we did in Spain to compare intravenous fosfomycin initially and then switch to oral fosfomycin compared to ceftriaxone or meropenem, depending on the susceptibility, for the treatment of a bacteremic UTI caused by a multi-drug resistant E. coli. So you see that it was a multi-center study in Spain, and we had problems to recruit a high number of patients. So at the end, we 70 and 73 patients in each of them. We tried to use a very practical protocol, very pragmatic protocol, and even though it was not easy to do that, we allowed switch to oral therapy. We tried to do a follow-up similar as we do in clinical practice. That allowed us to include aged patients. You know that the median age of patients is quite high. A patient with significant comorbidities, like 1/3 of the patient have a Charlson score of 3 or higher. And as you can see, we allowed the oral switch that was performed in a high proportion of patients. So what we found in this study is that regarding the endpoint that included macrobiological cure, it was clinical and macrobiological cure, because we tried to follow what the regulatory agencies were proposing. Fosfomycin could not demonstrate the non-inferiority because the margin of the 95% confidence interval of difference across the pre-specified limit. But if you look at what happened with these patients, there was 6 patients were withdrawn with fosfomycin because of adverse event. Most what they have was there was patients over 80 years with chronic heart insufficiency who get worse with the fosfomycin, and that's sodium, you know, in their composition. And there was some patients that were missed for the follow-up. And in intention to treat, you have to count them as not success or failure. But if you look at the patients that were evaluated per protocol, so when patients could be evaluated at the very end, the efficacy of the drug was very high. So fosfomycin cured 96% of the patients, which is even higher than that by the comparator. So it's not a problem of efficacy, it was a problem of safety and some missing patients. So we were quite confident to say that fosfomycin seems to be effective, and the only problem is that we need to be careful about adverse events. We did a small sub-study studying the rectal colonization for the acquisition of ceftriaxone or meropenem bacteria that was more frequent in the comparator, suggesting that, as expected, the ecological impact would be lower with fosfomycin. So in conclusion for that study, we said that fosfomycin looked to be effective. We have to be very cautious with the development of heart failure in aged patients with chronic renal failure or other problems related to sodium management, and it has a potential ecological advantage. So we need to do more studies with this drug. A very interesting study was performed by the group of our moderator, by the group of Marc, Baptiste, and Doshat. As you can see here, they compared fosfomycin, oral fosfomycin, and with oral ciprofloxacin as step-down oral treatment for E. coli febrile UTI in women. So these patients were treated initially intravenously and then were switched to an oral treatment. Very interesting, the fosfomycin was very efficacious in this sense. They treated the patient with 3 grams every day. And as you can see here, they could demonstrate clinical efficacy compared to ciprofloxacin. But if you look again at macrobiological failure, you can see that macrobiological cure was less frequent with fosfomycin, but it was not followed by a real increase or a significant increase in the number of relapses. There was 2 relapses, but not as many as you would expect, just because there was a clinical macrobiological failure. So again, we have doubts about using macrobiological failure as a good endpoint for these studies. We also analyzed what happened with oral fosfomycin in the FOREST trial, which is the result here. And in the 3 studies, the one that I commented before by Mark Drup, on other studies, there was an observational study. In the 3 studies, the results suggest that fosfomycin could be an alternative for oral step-down treatment in selected patients as usual, or in patients in which other options probably are not suitable. What about another very interesting drug is temoxilin. Temoxilin is active against ESBL producers and against AMC producers, and there are other mechanisms. So in these studies, our performed in Sweden, our Swedish colleagues compare cefotaxime with temoxilin in febrile UTI, and they were worried about efficacy, but also very much worried about the ecological impact. And they compared the colonization with resistant Enterobacterialis or toxin-producing Clostridium difficile. And what they show in the study is that there was no significant difference in early or late clinical response, etc. So the drug was efficacious. But very important is there was a significant result in favor of temoxilin about having a lower ecological impact with the disturbance in gut microbiota that cefotaxime. So this is a very important endpoint to consider in our trials as well. So how should we try to do trials in the future? Well, clearly, because of everything that we commented before, they need to have information about the whole process. They need to have very efficient protocols. We think that trying to do platform trials will be really a very appropriate way to try to do that. A platform trial is a trial in which first different type of comparisons, even different type of domains can be included. So you can compare empirical treatment, then you can include targeted treatment. You can include as well a switch to oral therapy, duration of treatment. So patients can be randomized in different domains. Another important characteristic of this study is that they are transformative. You can modify the study along the way by doing, let's say, almost real-time interim analysis, and with Bayesian techniques, some of the arms can be dropped because the probability that they will be successful is very low. Other arms can be introduced because whatever the new drug is coming in, or a new evidence of something that could work may be introduced as well. And you can also modify and change the sample sizes and sample comparisons, and trying to have a final result that could provide information for many of the different aspects that we would like to have. So this is a challenge that has been successfully developed during the COVID-19 pandemic, and there are other studies in other fields like Staph aureus bacteremia with the SNAP trial, and as I said, studies in COVID-19 or in pneumonia like REMAP-CAP, and other studies are being performed. Importantly, this trial, there's a way to do, if we compare with let's say the traditional trials like in scenario 1 or 3, these type of trials in which we include several arms at the same site and with a transformative trial need a lower number of patients. So we can provide a response for several questions with a lower number of patients, so they are more efficient. Also, another aspect to consider is what is the best outcome. Well, there's a lot of discussion about this. We typically use yes, no outcome, cure, no cure. But the patients, a patient can be cured, but as we show in the FOREST trial, it can have events or may have a recurrence or a problem. So we would like, it would be very important to know if we can summarize all these outcomes in a joint result. One way to do that is the use of DOR analysis, desirability of outcome ranking. So the patients are classified according to all these variables. Of course, if the patient died, this is the worst result possible, but if the patient had clinical cure but have a recurrence, is worse than if a patient has only a clinical cure but no recurrence. So you can rank the patients according to the occurrence of all these variables, and then you can calculate the probability of having a better door or for the final outcome. But of course, there are a lot of issues, and we have not time to discuss this in detail, but this is an interesting aspect to consider. This is an example of the comparison in different pivotal trials. So the patients with the best outcome possible are in the green, and you can see the comparison in 3 different trials, and then you have, let's say, a less desirable but still good in light green, and then worse outcomes in yellow or orange or red. So by doing that, you can also have more information and provide more specific information, and you can also detect by prioritizing some of the aspects or doing some subgroup analysis. You can probably detect some areas in which either more studies are needed or in which there's suggestion for some better results than just providing a simple outcome in the study. Again, there are many issues to consider there, but it's an interesting way to think. I was telling that in some patients, the alternatives are not that big, and then you cannot just compare A versus B because the patient is resistant to both, or because one of the options is not the most suitable for your patient. So what we do in clinical practice is that we take individualized decision according to the bacteria, but also according to patient features and other conditioning. So one way to look at it is to try to see if we can perform randomized trials that analyze personalized decisions. So there is a very nice proposal from the Oxford group, as you can see here. So the patients with a very extremely resistant pathogen, like carbapenem-resistant gram-negative, for each patient you just list the possible treatment that you could use in that specific patient. You can consider renal insufficiency, you can consider other characteristics of the patients, and then that specific patient will have a list of potential options, and you will randomize the patient for his specific or her specific options, not will be the same option for all patients, and then you can try to analyze that in conjunction. So taking that example, patient number 1 here, according to all these options that you have listed here, some of them may be an option, some other not. Patient 2 will have these options marked as yes, but not this marked as 2. So this patient will be randomized only to those that are really an option for them. And then, of course, the analysis is complex, but potentially doable. So this is something that we should consider also in our studies. Well, how to do that in practice? How to implement that? Well, in ECRAID, I think there was a lot of discussion about this, and one decision was that one way to try to perform this trial would be by having what are called perpetual observational study. What is that? This is a study that is performed in a high number of hospitals, like 40, 50 hospitals. These hospitals are trained in detecting the patient, having informed consent, collecting the data, following them like in a randomized trial, but they're doing an observational study. So we have a perpetual observational study in complicated UTI. We are collecting patients from all these patients, and eventually a new drug comes. There is a proposal for a randomized trial. There's a proposal for a platform trial, and those sites will be very much trained to very rapidly get incorporated into the trial and eventually very efficiently capture patients and try to recruit them for the trial. So this is more or less the philosophy. So for the post-complicated UTI, the overarching objective is to build a sustainable network that will facilitate clinical studies. Of course, we will do some specific objectives like evaluate the practices, collect information to design trials, and describe patient population. Of course, we will analyze the outcomes, the outcome predictors, and so forth. But the most important thing is that we are building a sustainable network and will be very able, in our opinion, to do clinical studies. So the idea is to have a high number of sites, like 40 sites, recruiting each site 50 to 100 UTI per year. Sorry about that. I should go to the previous slide. And trying to get from them what we do in trial, informed consent, apply the criteria, follow them, have quality monitoring. So these trials are very well trained. How are we doing? So we have 41 sites as per today from all these countries that you can see in the slide. So we are very grateful for all the site participating. Fortunately, things are going very well. We will reach 1,000 patients by end of this month. The latest data I got this morning is 900 something. So patients already recruited and under 4. Very happy to see that we have been able to recruit in a number of patients under those conditions. Yet a very fast slide with data. So 51% are male, 50% of the infections are community, and 24% are in hospital. Bacteremia, 19% have pyelonephritis, lower than in the pivotal trials. Source control is done in 22% of the patients, and most of the study, half of the study, are keeping the store so we can analyze them later. And you can see that the result for clinical cure is around 70%. So in conclusion, I would say that there are many important medical questions to be answered in complicated UTI. This is a very frequent syndrome and very important for the use of antibiotics. Innovative design may allow a higher efficiency in recruitment of patients and also provide results that are more applicable to clinical practice. And within the post complicated UTI that we're performing with ECRAID may be instrumental for these objectives. So I will finalize by acknowledging all the people working in our team for the post-UTI. They're doing a fantastic job. Of course, to all investigation from all sides, doing a very hard work as well, and to the ECRAID network for allowing this and for having the vision to allow us to develop this type of studies. Thank you very much.
Thank you, Jesus. We will take questions at the end. And our next speaker is Julia Bielicki. She's a consultant in pediatric infectious diseases and infection prevention and control at the University of Basel Children's Hospital. And at the same time, she heads the hospital's pediatric research center at that place. She's engaged in several large-scale national and international projects. She's also a reader and senior PI at the Center for Neonatal and Pediatric Infection at St. George's University of London. And she is the working group leader for for severe bacterial infections and AMR at PENTA, which is a clinical trial network for pediatric infections. If you would think she would fill her time with that, no, she's also involved in developing a national antimicrobial stewardship program in Switzerland. And Julia's research focuses, as you can imagine, on many aspects, observational and interventional studies to improve the use of antibiotics to treat neonates and children. She has a particular interest in best-in-class antibiotic use and prescribing practices, as well as innovative approaches to infection prevention and control in low and middle-income countries with high prevalence of multi-drug resistant bacteria. Today, she has authored or co-authored over 100,000 papers and book chapters, and as you will hear from her in the presentation, more will follow. Please, Julia, start your presentation.
Excellent. So thank you very much for the introduction. And thank you for giving me the chance to present. Let me just see whether I can actually move slides. Yes, I can. So my presentation will be maybe a little bit more conceptual than the presentation that Jesus has just given you. But interestingly, and we did not arrange this in this way, there will be a few references to some of the designs that Jesus has already mentioned. So I'll be talking about SNIP-AFRICA, which is a project that has only just started. So for that reason, the talk will be slightly more conceptual, as I can't really present any results to you yet. That we started on the 1st of July, and the plan for this project is to build a severe neonatal infection platform focusing on sub-Saharan Africa. And to start with, I would like to just highlight that what I mean by platform is maybe not what everyone else has in mind when they talk about platforms, because in the context of SNP, this is really really relating to a sort of infrastructure or architecture of research that allows us to test multiple primary questions within one consortium or group of sites, but also working to one core protocol with multiple associated domains. So it's really an opportunity to conduct gold standard clinical trials with adaptations, both in terms of the questions that we might want to ask, but also within the trials themselves, to emerging evidence, and in this particular case, antibiotics of interest. So it's really planned to be flexible, but has a sort of almost like general terms and conditions that reference an overarching patient population, disease and outcome assessment, so that all the elements on the platform can talk to each other. And so a part of what we'll be doing is to actually build a coherent governance structure to allow us to move forward with this. So here is just a list of the objectives for SNIP-AFRICA, and you can see that there's two research activities that are incorporated. One is to implement an adaptive trial in the extended spectrum beta-lactamase drug regimen domain, and I will explain to you in a bit more detail what exactly this means, but also to conduct a pharmacokinetic study in the dose domain. And you can see that there's quite a few other supportive objectives that really go back to what I started off with, that serve to make sure that all of this architecture follows a coherent plan and hangs together in a sensible way. So I'm going to get my acknowledgements out of the way here. I haven't listed the institutions, but you can see that actually this is a collaboration between institutions in the global north and in the global south. This is the way that we've organized ourselves. So essentially all of these different elements are work packages, and I'm very pleased to say that 4 of the 7 work packages are actually led by our colleagues in sub-Saharan Africa, including the pharmacokinetics domain that is under the leadership of Stellenbosch University, the clinical and microbiological surveillance work package, which is under the leadership of our colleagues in Kenya. Then training and capacity building, which is led out of Ghana, and stakeholder engagement and integration, which is led out of Uganda. So this is something that is really critical when you're trying to build such an architecture that really, if the burden is in a certain setting or place geographically, that the engagement of researchers from this setting is also there from the start, and they are involved really in shaping that architecture. So just because this is potentially of most interest to people, to show you the 2 clinical studies that are planned up front. One of them is called Precision, and it's an pharmacokinetics and safety study of colistin, also exploring whether colistin load and dose is required for a population that is generally doesn't have a current dosing recommendation for this very difficult to use antibiotic, and we'll be focusing on neonates, but we have built this in such a way to have the opportunity to also address this question for older infants and children less than 2 years. And for all of the trials or studies that are happening within this platform, there is always the aspiration to develop templates that will be available for future researchers, either from within the consortium or external to it, to pick up and then replicate some of these studies, perhaps for another drug, but building on templates that are then already available to them. So this includes structuring the appendix to the core protocol for dose confirmation, dose finding studies for antibiotics. It also includes developing ECRFs that can allow standardized data collection and developing a template for how to analyze these data. Then the second trial, which many of you might have heard about already, is NeoCep1. NeoCep1, of course, is a trial that is sponsored by GARD-P, who are hosting this webinar today, and is actually much larger than just SNP, but it is incorporated, the African part is incorporated in SNP, and this is the ESBL drug regimen domain that I was alluding to before. So this is an open label randomized control trial comparing novel combinations and currently used antibiotic regimens for the empiric treatment of neonatal sepsis in settings where gram-negative bacteria are dominant as causes of neonatal sepsis and where ESBL prevalence is high. And so again, you know, we are using the opportunity to do some development of templates that will be relevant for other trials that may be hosted within this architecture. But I just want to share with you now a little bit more detail about NeoCep1. So, I mean, why is this the trial that we've focused on as a sort of proof of principle to test this architecture of SNP-AFRICA? So the main reason is that we know, for example, from the global burden of disease studies, that a disproportionate burden of antimicrobial resistance falls onto neonates, and that WHO has not revised recommended therapies for empiric treatment of neonatal sepsis for a very long time, essentially because also the evidence was not generated to support such a revision. And so we are observing that an increasing resistance to these WHO recommended regimens amongst newborns. Also, neonatal sepsis is a potentially modifiable cause of death because it's, at least in theory, treatable. And so addressing neonatal sepsis will go a long way to reducing neonatal mortality, which is one of the impediments to reaching the Sustainable Development Goals in the area of child health, because neonatal mortality is improving at the slowest rate. So I will give you a little bit of background to illustrate this from NeoObs, which was the observational work that was done to inform NeoCep. So here are data from 19 sites in 11 countries, mainly from low and middle income countries, not just sub-Saharan Africa, also countries in Latin America and Asia. And you can see here resistance that was observed amongst Klebsiella pneumoniae, which was the most commonly isolated organism in this observational cohort study of babies with neonatal sepsis, when cultures were positive, and resistance among E. coli, which is still quite considerably high to WHO recommended second-line therapy, and E. coli was the third most common organism isolated in positive blood cultures in this cohort. Overall, about 20% of the babies had positive blood cultures, so for a lot of them, and this is true also going forward, we may never be able to isolate an organism, even though the baby's behaving clinically as though they have neonatal sepsis caused by a bacterial infection. Now, these resistance patterns, of course, drive a lot of deviation from WHO guidance, which would recommend to have this group 1 access regimen, so essentially a combination of benzyl penicillin plus gentamicin or ampicillin plus gentamicin as first-line treatment for these babies. And you can see that there are quite a few sites, they're pseudonymized or anonymized here, of course, that will not actually initiate this kind of regimen in babies with neonatal sepsis, but will immediately move to either piperacillin tazobactam containing regimens, or even carbapenem-containing regimens, here in the dark orange, or in fact go to colistin as the first empiric treatment of choice. And in line with that, we also see frequent escalation and switching, and we see that a lot more babies end up on these broader spectrum regimens compared to the recommended first line through switching, then even start at the beginning on this WHO recommended regimen. So you can see that the challenge in this, so neonatal sepsis is something that's difficult to identify clinically, and often we will not have a confirmatory culture even when we are convinced as clinicians that the baby does have neonatal sepsis caused by a bacterial infection. There are multiple bacteria that can cause it, many of them affected by increasing AMR. And as I've just shown you, there isn't a single accepted standard of care regimen, even though recommendations focus very much on this combination of a penicillin plus an aminoglycoside. And so any pairwise analysis with a standard of care is really inappropriate, which is what you would do in a gold standard RCT, where you randomize patients between the standard of care and some one or more options, but the comparison is always to the standard of care. So we've actually decided to take up the design that Jesus has already conveniently presented to you. So this practical design, which is essentially the reference that he also shared with you. And we're combining this with a sequential multiple assignment randomization called the SMART design to also accommodate this frequent escalation to second line options, where we are just as blind as in a way in terms of the effectiveness of these regimens, and we want to study this as well. But the important thing is that within this design, sites will decide the range of acceptable first and second line options, and they will be given some guidance to really also address this SMART element in terms of when to re-randomize. So this is what it looks like in a picture. Babies are screened, they are enrolled based on clinical signs, and they're randomized to their first treatment, and if they clinically improve, they basically are followed up in terms of duration of this treatment, etc. This is really something that is a clinician decision, and we assess our primary outcome in 28 days. If they deteriorate or fail to improve, and this is where we are giving some guidance as to how to determine that, they would undergo a second randomization and again be followed up to 28 days. This is the way that we are interpreting the practical design in NeoSEP1, where we are using all sorts of factors that we are discussing with sites and saying, well, are there differences in regimens that you feel would be acceptable according to these different factors? To anyone who's familiar with neonatal sepsis, these different bins or buckets will look very familiar. And so, but ultimately, this is something that's determined by the site in conversation with us. And the way that this works is that you basically have a master randomization list for your first randomization and your second randomization, and you have discussions with sites about which kinds of babies they are currently treating. So who are their big populations and how are they characterized, and which regimens would they feel would be appropriate for this first and second randomization for these babies. So what's happened is that in conversation with the sites, we've already eliminated some regimens that are never used. So we are true to the design, also not offering them, because if sites are not interested in using them, then there's, in a pragmatic trial, no point in investigating that further. And then we have conversations with them about the sort of buckets that they might be looking at. So I'm showing you some examples. This is an early onset sepsis kind of group where this one site has said they'd be happy to randomize to ampicillin gentamicin, which they do use frequently, and the 3 novel combinations. So in that site, this baby would then, these types of babies would then be randomized between these 4 options. Whereas there are some options that perhaps are equivalent, and for a baby with a late onset sepsis acquired in hospital, you know, a site might then choose to randomize between the novel regimens and something that is broader spectrum and covers the types of bacteria that they typically observe in these babies with hospital acquired late onset sepsis. So that's NeoSEP, and I'm not going to go through the second randomization because it'll get very complicated, but I'm happy to discuss if anyone wishes to do so. I just want to come back to that platform idea. So it's not really a platform trial, but it's really a platform to host these types of complex designs. And so work package 3 is our governance work package. You can see that it basically coordinates all of this standardization and template development and thinking about how we integrate new questions into the platform. Work package 6 is our stakeholder engagement, 7, excuse me, is our stakeholder engagement work package. And so they are always there in the background to make sure that whatever we develop in terms of templates is something that is acceptable both to potential sites, also regulators, and ultimately also families who are obviously very important in this. So this is an example of what this could look like. You know, you have work package 4, it feeds into these templates, you define a dose for an antibiotic of interest that is likely to be effective, and then you feed it into, for example, NeoSEP 1, and this is supported by this regulatory work package that's really cross-cutting. Similarly, if we focus on work package 6, which is our training work package, it basically it goes into the other direction, where it receives information from each of the trial work packages or more research focused work packages to make sure that all of the sites and all of the investigators that come together within the platform have appropriate training and really have maximized capacity to deliver these types of complex research programs. And again, this is where work package 7, so our stakeholder engagement work package, is really critical because it also addresses clinicians, nursing staff, etc. at these sites. For these types of trials, it is really important that there is maximum support in participating neonatal units. And again, just to translate how this all hangs together, this is now focusing on surveillance, but you know, you then have surveillance that is developing a specific approach to monitoring microbiological outcomes that feeds into capacity building and training. It also feeds into, again, the trial or trials to really detect these resistance outcomes, and is supported by any of the regulatory input, but also other stakeholder input in terms of making sure that what we are planning is acceptable and in line with local and diverse laws and regulations. So I want to finish with this because I want to come back to what I started with at the beginning. Is this is something that really we are hoping to have as much input and drive from our African colleagues as possible, because they understand the local need for this type of platform much better than we do. So we are really focusing a lot on south-to-south collaboration, on also face-to-face, south-to-south training, rather than shipping things off, you know, to the UK, to Switzerland, or Belgium, or wherever it might be, to really make sure that these kinds of questions can be addressed where they're most pressing. And so the way that we see SNP really is for us to allow it to be a seed for hopefully a platform and architecture that will grow to then also reach out to other regions in the world, including through NeoSEP itself to colleagues in Southeast Asia and elsewhere, so that we can really fine-tune that kind of platform. So again, not a platform trial, but that kind of architecture that will allow people to collaborate efficiently and address the multitude of important questions in the area of neonatal sepsis. So thank you very much for listening, and as I said, I'm happy to discuss any questions that might come up.
Thank you, Julia. We will start now. We will now start the Q&A session, and you can send your questions through the webinar platform. And as a quick reminder, we will do our best to respond to as many questions as possible during the allocated time that we have. So here on screen, you can see how you can address a question to us. I have a first question for Jesus. And that is on the role of cefepime and metazobactam. Must admit that I didn't know that one yet. So the role of cefepime and metazobactam for carbapenem-resistant infection, and whether that is included in any of his trials.
Thank you, Mark. Very good question for a drug for which we have. There is a randomized trial already published comparing this drug with piperacillin tazobactam, a pivotal trial was published in JAMA, suggesting even superiority in some of the endpoints compared to piperacillin tazobactam, which, by the way, might not be the best comparator for complicated UTI in trials. Some discussion about that as well. It is active against some carbapenemase producing, not many, depending on the type of carbapenemase, and also depending on other mechanisms of resistance that the bacteria may co-produce. But it could be an option for some of them. I think that if we plan, of course, if we plan, or there is a possibility to do a personalized medicine trial like practical that Julia discussed about, or something similar, I would include it. For other circumstances, I think that it could be included as a targeted treatment after susceptibility result. So could be an option for one of the domains, one of the comparators of targeted treatment. I probably will not include it as empirical treatment if we are populating XDR population, like patient colonized and so far. But as a targeted treatment could be very interesting.
Yeah. The question to Julia. So, in your study, how would you define neonatal sepsis?
So again, we've built on the NeoOBS cohort data to deal with that. Essentially, what we're interested in are babies with clinical signs of neonatal sepsis. There's no point in postulating that they have to have certain lab values, for example, because in the type of setting where we're doing the trial, these laboratory tests might not be available. And we actually want to enroll babies with a high risk of mortality. So part of NeoOBS, what we used to develop and validate, at least internally validate, a neonatal mortality risk score that you can apply at baseline. And so we are basically looking to enroll babies with clinical signs of neonatal sepsis, and neonatologists will be very familiar with those, and who have a high risk score on that NeoOBS mortality score, because they have a high risk of dying. And by doing that, what we expect to see is about 20 to 30% of the NeoSep1 cohort being culture positive, and that's what you would expect in this type of cohort. So slightly higher than we've seen in NeoOBS, where we also enroll babies with less severe disease, so they also had these clinical signs of sepsis, but may not have had such a high risk of dying from this within this episode. But essentially, that's what we're expecting to get. I don't know whether that answers your question, because, you know, the debate on whether these culture negative babies truly have sepsis or not is one that, to my mind, is very difficult to resolve.
Yes, but that's the beauty of being a PI of a study, that you can make a very clear definition of your entrance criteria as well as your primary endpoint.
Yeah.
So there's another interesting question, and I think it could be addressed to both of you, as you both used let's say, used the reference of the personalized RCT designs. The Sarah Walker paper, the viewpoint in Lancet Infectious Diseases, which is, I think, a fascinating design. Now, one of the questions that was raised is here, or the question was asked is, what do you do to the availability of these antibiotics, and how does it impact your trials? And for such a trial, would you specifically purchase them in advance? So how would this work in practice? Because some of these may not be available in all countries or at all places. So how would that work?
Yes. Do you want me to go first, Jesus? Since we have thought about this already. I mean, this is always a dilemma, but because this is really a design that in our case we're using because it answers a question about effectiveness, not efficacy, we have gone down a mixture of paths. So we are making the novel antibiotics available to all the sites that are participating in the trial. And this is actually also by our funders for SNIP expected to come with an access plan that GARD-P, who is the sponsor of this trial, is also actively developing. So if you find that these novel combinations are more effective than alternatives, how do you make sure that they continue to be available in the sort of settings where the trial is taking place? For the other options, so all the ones that were in colors other than orange on my long list, actually this is something that sites incorporate into their decision as to whether to randomize to a certain regimen or not. So there are sites that will say, this is an antibiotic we never use, never mind whether it's available or not, but we just don't use it and we don't feel it's appropriate to randomize babies to this option. And that's something that we accept. We wouldn't try to convince them otherwise. The question is not so much about buying them and making them available, because we've actually identified that other than these novel regimens, most of the time they're available, but it's actually patients who often have to pay for them in these sub-Saharan African settings. So they're available if parent can go and buy the drug. And that is something that we are, for ethical reasons, trying to avoid in the trial. So we are actually paying for the treatment that all the babies are getting in the trial. And so sites are encouraged, if the antibiotic is available and they may consider using it, to also include it in their randomization lists. But again, this has to go with an access plan for what to do afterwards, because after the trial, if, you know, say piperacillin tazobactam is for some reason a miracle drug in a certain setting, and it's one that parents typically have to pay for, you have to consider upfront how you're going to deal with the fact that this might be unaffordable to a lot of patients after the trial.
Yes, that's a very clear answer. Thank you. And it creates a new paradigm shift that you pay for your own randomization. That will be it. Jesus, you wanted to add something on this?
Yeah, we're struggling with that also in the design of a similar study for adults, as you know, and this is a big issue. And if you here, there is of course a very important open door for private-public collaboration, and therefore the option would be that this platform trials is also funded by some companies who might be interested, but it is very complex because you need to populate all participant sites with the drugs. Some of them, as Julia would say, will not be used in one specific hospital because of their local epidemiology, etc. So there are many barriers there, but I agree with Julia. We need to find a way that for ethical reasons, all sites have the drug that are options available.
Yes, and this creates some ethical issues because as a pharmaceutical companies, you could drive such a trial towards your own drug being one of the few that can be analyzed in the end by making it widely available. Okay, so there's more questions on this, on the platform clinical trial design aspects. Someone asked that stopping an arm and starting a new one cannot be easy during such a trial because you need to, let's say, the cleanups and the regulatory perspective needs to be addressed, and it can create a long gap in between. What is your experience as such? So when you do a platform trial and you're confronted with an arm that's being stopped or a new one that is included. Let's focus first on the one that is being stopped.
Well, I think that this has to be very clear in the master protocol that must be approved by the ethical board. So as long as this is, let's say, pre-approved by the committee of ethical board about what is the procedure and when you can stop or not one of them, our experience, and there is some experience in COVID-19 by doing that, is that reporting the results to the ethical board is enough for stopping one of the arms. So we didn't find much problem about that. Could be a bit more difficult to include anyone if that was not pre-established or pre-planned. But again, if the whole procedure, I mean, we did something also we need to do is to work with our ethical experts and ethical boards to understand and know what these designs are for and how important is that any change along the way have to be done, you know, in a very rapid way. So I think that for stopping, was your first question, we didn't find that problem in some of the trials that were performed during COVID-19. I don't know if Julia have any other events.
Yeah, I mean, I'm quite conservative with regards to stopping, as you know, Mark, because you know dropping arms can be risky in itself because you may be dropping something that actually has effectiveness. It just might be performing slightly worse than something else. So I think for the practical design, actually, in a way, stopping arms is not. I'm not sure that that's really a primary question. So we have some provisions for that in our protocol, but I think that actually that's unlikely to happen. So the way that we are approaching this is that we are just not including regimens that in theory might be interesting, but no one is interested in. So we are kind of stopping things even before we started, in a way, if that makes any sense. But I think in general, I mean, that tension that you describe is something that is just quite difficult to deal with, particularly for things that are treated for a very short period of time. I mean, I think infections have a hard time with these stopping and adding elements compared to where platform trials have come from, which is cancer, where of course patients will be treated for much longer and will be followed up for much longer typically. So I think that that is work still to be done in the community, say through ECRAID and other players like that, to really find some sensible ways of facilitating that when it's appropriate.
If I may add, I think that also having predefined hypotheses for drugs that have lower probability initially for being successful makes things easier. I mean, azithromycin in COVID-19, you know, we're already having enough data, and we just saw the first data that it didn't work, made it very easy to stop that arm in the trial. So, but it's more difficult, I agree with Julia, when you have no previous information or what the previous information that suggests that a drug could be efficacious, and then you find a very preliminary analysis suggesting the other way around. I agree with that. But if you have a hypothesis suggesting a lower efficacy, and then you, let's say, confirm that in one of the initial interim analysis, I think that is reinforcing.
Yes, I can add to that my experience in REMAP-CAP, where this actually happened. So there's two ways of stopping a treatment in a certain domain. One can be actually a conclusion from your study that a certain intervention is, according to predefined rules, considered inferior to other treatments. And then it's no longer ethical to continue randomizing patients to that treatment and you stop that arm. That's what we call a platform conclusion, and can be reported, can be published. It's important information. The other thing that can happen, and that was what Jesús alludes to, is external evidence. We were doing in REMAP-CAP also a domain on corticosteroids at the time that the recovery results on dexamethasone became available. And these were so convincing that we immediately stopped or interrupted randomization to the control arm, which was no corticosteroids, did the analysis of the data that we had, and had a posterior probability of also close to 90%, which was pretty high. So it confirmed that finding. So the external evidence can also lead to stopping of a treatment arm. And the beauty of the platform trials is that that is possible, that you don't have to discontinue your complete study and start over a new study. You can continue with the other randomizations, but you can stop this one. And that's also the question, another question is, and this is very close to this, so what can you do in your platform trial, for example, in NeoSAP, if your trial is up and running for 3 years, you're happily recruiting patients across the world, and then a very new promising antibiotic is presented and marketed and available. What to do then?
So actually, we have a kind of contingency for this situation, because of course there are drugs now that are coming onto the market that might be relevant to babies who have who are experiencing neonatal sepsis where ESBL prevalence is high. And I mean, so we have provision again to include this as an additional randomization option. But for the practical design specifically, you have to then be aware that that has sample size implications that are quite considerable, because of course the design is built in such a way, well, it basically, and I'm not the best person to talk about this, but it uses essentially a statistical analysis that is akin to network meta-analysis. So essentially direct and indirect pairwise comparisons between all the options that are being used in the trial as randomization arms. And so if you introduce a new drug, you may find that depending on how much better, how much more effective you expect it to be, you may have to extend your trial quite considerably to allow any meaningful comparison of that particular option within the design. So that is something that I just can't answer how we would deal with that at the moment, because we haven't thought it through to that degree yet. But essentially, it's mainly a question of sample size and power to really detect the effect of that particular option going forward, and it's quite possible to include it.
Thank you. So I think we're now coming to an end of the Q&A session. There's one last question that I would like to ask both of you, because there might be young investigators listening to this webinar. Our generation, my generation and your generation, has been raised with the concept of the randomized controlled trials. You make two groups, you follow them for years, and you see what happened. This is the opposite. You start and you have no idea where you will end, or actually the trial may never end. It may be a perpetual trial. If you're now an interested researcher and you want to embark on this, where should you start? What to do? Jesús.
Okay.
Yeah, so the first part I could not hear. So
I think that to trend.
Yeah.
Can you hear me now? Yeah. So I think that somehow we need to get out from the idea of doing small randomized trials that I can lead as an investigator and be like the first author of a paper or whatever, and go for big consortia in which every one of us can collaborate and contribute to really make out the questions that patients are worried about and the medical needs. And that creates an additional challenge: is what is the role of individual investigator, individual teams in that big consortia. But what I would do is to try to contact one of the consortia that already exist, or ECRAID, for example, and try to get involved in that and try to participate in that. I think that we are in changing the way that we feel about authorship or all those issues, and try to be more practical about what we need to develop for our patients. This is a change in mind, but I think that's a way to really go.
Yeah, and Julia?
Yeah, so I think in general, I mean, I think I have maybe two things to say. One is, I mean, I feel that any young investigators who are listening or come across this and feel like they want to do a trial, I would say that's going at it backwards. I would say, you know, identify the question that you are interested in and passionate about, and then find people who are doing trials that answer that question. I mean, it's really doing trials for trial's sake, whether they're standard RCTs or novel designs, is probably not quite the right way to approach it. I think in general, if you want to get involved in these kinds of activities, I would say the easiest route, if it's possible, is to become a site and a site PI. I think that's often something that is extremely helpful, because I think that actually running these types of trials eventually, whether that's a group or a smaller or a larger group of people, is often done best by people who have been PIs and enrolled patients into trials themselves. Again, whether that's a standard RCT or one of these novel designs, in a way doesn't matter. And I mean, to come back to this issue of, you know, is the RCT dead, which is essentially what you kind of started with. And I think it depends on the question that you're asking. For some questions, a standard one-to-one randomized control trial will be the appropriate design, but for other questions it won't. So it comes back to what I started off with. I think it's important to identify individuals who are asking similar questions to the ones that you're interested in and trying to reach out to them. And sometimes the easiest way of getting involved is by being part of the trial. Often the first step in that is being a site in the trial, if that's something that can be done.
Thank you. I think that's a very good recommendation. Start learning the work by being a site in a trial. And of course, the RCT is not that, because indeed there are many questions that can be answered very simply with an RCT. Just as a final remark, that there is in preparation a webinar series from ECRAID on the methodological aspects of adaptive platform trials. So if you're interested, follow us from ECRAID, and that will be notified. And I think the first webinar will start somewhere in October, November, but please follow us, and then you have the opportunity to follow that webinar as well. I thank our speakers. I thank you all for listening, and Shireen, I now hand over to you.
Thank you so much, Marc, for moderating today's session. Thank you so much, Julia and Jesus, also for your presentations, and also the very nice question and answer session that we had following that. I would also like to invite everyone to register for our upcoming webinars at GARTP later this month. So you can find the information and registration links on the Revive web page that is here at the bottom of your screen. I also wanted to say to keep an eye out on our latest updates on the Revive website, and by keeping connected via our newsletter, as well as our Twitter and LinkedIn page to stay up to date. And that's it for me. Thank you everyone for joining today, for contributing to the discussion, for sending in your questions. I hope you found the webinar interesting and useful, and that you will join us again later in the future. Please also spread the word and encourage your colleagues to join. Thank you, everyone. Goodbye.
Bye-bye. Thank you.